Welcome to Beyond the Call podcast, where we tell the stories of those people behind the jobs we rely on. We go into the good, the bad, and the ugly, and we shine a light in what can be a dark place. Just a warning, the content can be graphic and distressing, so please use your discretion. Please like and subscribe on your podcast platform and our social media. And if you have feedback, I read every single one. Let's get on to this episode of Beyond the Call. G'day everyone, welcome back here to another episode of Beyond the Call. We are continuing our conversation with Adam. So Adam is a pediatric intensive care nurse and a nurse practitioner in America. What state are you in now?
I'm in Colorado.
In Colorado now.
Yeah.
Yep. Please make sure you listen to the first episode. It's, look, this is a deep and dark discussion, but it's also informative and we're going to have a laugh as well. So, So we ended up on our last conversation on a positive, and we were talking about advocating for our patient, and sometimes the system doesn't allow that. And then, and during that conversation, we sort of brought up the topic of organ donation. So, what's the system there of organ donation?
Yeah. So when a patient is near the end of their life, we have to notify Donor Alliance. They would then kind of review the medical charts. They have access to all of our records in our system. So they review things. They usually call back with questions, talk to either myself or one of the physicians and get more information about what's going on. And then at some point, they decide to approach the family. So we have to notify the family that it's part of our obligation to notify Donor Alliance, and that typically there is some kind of point of contact that they will have with the family. The family can straight out refuse to talk to them if they don't want to get any more information. That sort of should be the end of the discussion. Sometimes they are a little pushy and they will come anyway, and they'll meet with them and just say, hey, this is what we offer. And honestly, like for the families who are open to it, it is a beautiful way to create a legacy for their loved one. Their organs go to saving lives of potentially multiple children. A liver can be split up in multiple parts. That could be 3 or 4 lives there. Like, there's a lot of potential for good with organ donation, so I don't wanna knock it. But the way that the system is set up is that it's sort of expected that people will wanna donate, and when they don't want to, it's sort of met with resistance.
Yep. Do you guys have like a registrar or something you can do while you're alive that sort of nominates your preference?
So like our driver's license is one of the questions on our driver's license if we're an organ donor or
Yep.
not. And so there's ways as you become a teenager to designate if you are a donor or not. And
Yep.
families should respect that decision, especially if you've announced that you are wanting to donate organs. Um, but I think it's more complicated. I don't work in adults, so I don't know exactly how that goes down. I think if someone has like power of attorney or they have medical decision making over you
Mm.
because you've designated them to be that person for you, I don't know if they can reverse that or go against those wishes. So I think it can get complicated even in adults, but in pediatrics, really the parents get to make those decisions. Children don't
Yeah.
really have a whole say unless they're older and they say, hey, I want to be an organ donor. But again, parents can. They're minors. Parents can say, no, we don't want to do that.
Yeah. I remember as I was becoming a young adult and going through, and getting my driver's license, people used to say you should tick no because it means they won't try as hard to save you. Which we all know is just a load of crap. And I can
God.
guarantee you that at an emergency scenario, I've never checked the license of somebody to see if they're an organ donor
No.
or not.
And just having a
Um,
DNR tattoo on your chest doesn't mean they're not going to attempt resuscitation.
and that's it. And people do that. It's amazing what they
Oh,
think
God.
counts. Um, Over here we have a donation register where you
Yeah.
can register as an adult, and I think what it does is it triggers a conversation, but ultimately your legal next of kin has the final say so.
Yeah.
It is a conversation that you need to have with somebody that is your next of kin while you are alive,
Yeah.
while you are well. Have it tomorrow, have it today. But yeah, have it today. Don't have it tomorrow because you're not, tomorrow might be the day that decision is made.
Yeah.
So yeah, it is we have, we are essentially an opt out
Mm.
country unless you opt in.
Hmm.
There seems to be a little bit of public will going the other way to change that,
Mm.
where it's going to be an opt-in. You're counted as in unless you choose to have an objection and opt out.
Yeah.
Personally, I like that idea. It doesn't take away, for me, it's not I've had a few people saying it's taking away my rights. Well, it's not. If you don't like it, just tick no
Yeah.
and you won't even be asked. So, but it is a conversation that people need to have while they are well, because you never know what this afternoon or tomorrow is going to bring.
Yeah.
Did within the PICU unit, was that a conversation you had to have often as far as donating?
Yeah, so when it does come up with families, sometimes they're very clear that they want to donate, and that's great. They have that clarity. There's, I think, a reality to donating that people aren't aware of that gets a little bit complicated and also potentially a little bit icky feeling.
Yeah.
The process takes days sometimes, and so
Mm.
if it is gonna be something like a bad TBI, where someone is gonna meet death by neurologic criteria, um, once that once they've declared someone as legally dead, um, they usually begin that process a little bit beforehand, but it can take a couple days to find matches, to run all the
Yeah.
blood work. There's a bazillion tests that they want done. Any physician who is potentially going to put an organ in their patient that's alive can ask for whatever they want from Donor Alliance to do tests on the patient who's going to be donating. And so
Yeah.
we end up doing stuff like sometimes we put kids on dialysis just to get them to donation, which again feels really kind of, that's sort of icky.
Yeah.
We're doing all kinds of unnecessary tests. We're doing, lots of antibiotics. We're doing a lot of things that we wouldn't probably be doing anymore. And so actually as things are kind of getting to the point where we realize the patient is going to die, um, there's this like re-ramping up of all the medical things, which doesn't
Yeah.
seem congruent with what's happening. The family's getting this
It's
process.
counterintuitive to do that, isn't it? Yeah.
Absolutely, right, and then, there's this debate right now that's happening where, um so, um, pa patients who donate either donate one or 2 ways, right? So, either they die, if say it's a patient who's on full life support, and they don't meet death by neurologic criteria, then they do what they call DCD, which is donation after cardiac death. So, they actually have to have their heart stop before they can then procure organs.
Okay.
But then what sometimes happens in the OR is they'll put them on bypass. They'll put them on ECMO to reperfuse the organs. So they're actually like they're basically bringing them back to life
Yep.
ish, right? Their heart isn't
Yep.
necessarily pumping, but they're on cardiac bypass, like on full life support
It's doing the job of the heart.
to then procure the organs so they don't get injured, which is, great for the
Yep.
people who are receiving the organs. But there's an ethical thing there where is that okay? Like, should we be doing that? Like,
Mm.
it's a big hot topic right now in organ donation, and this is stuff that we don't necessarily talk to families about because it is very like, if you're willing to do that for donation, why don't you do that now? And obviously,
Yes.
it won't change what happens to the patient, especially in, like, a bad brain injury or something else, right? Because, ECMO, which we can get to as well, right? Which is, basically doing either the job of the lungs or job of the lung and the heart, um,
Yep.
is a bridge to something, right? You don't just put people on ECMO and they don't live on ECMO.
Yep.
It's not feasible.
Otherwise, we'd just all be robots walking around with giant ECMO machines next to us.
Right, so it has to be a bridge to something, and so if there's no something waiting for this patient, you're not gonna do it. So doing it
Yep.
in a very short period of time during donation, it has its purpose, but again, this is a kind of moral and ethical dilemma. And it's one of those
Yep.
things where we don't necessarily discuss this with families because it opens up a whole can of worms. It's like Pandora's box. And then he's like, and then even providers have very different feelings about this. Like this is a very sticky and kind of contentious discussion that people are having right now around organ donation and procurement.
Yeah, it's one of those really tough, sort of, is the end game worth it? and so obviously, or the end game worth the cost of doing it. And like I am pro organ donation. If you are that way inclined and you want to do it, if I'm dead, my family know I want my organs donated. No
Yeah,
dramas whatsoever.
yeah.
My dad is actually donating his body to science. That is a complicated bloody process as well. Oh
I'm
my
sure it
God.
is.
But what on the other end of the spectrum with the donating things, have you had kids in the PICU who have received or that
Yeah,
has saved their
we
lives?
do get a lot of kidney and liver transplants at our facility, so we're one of the big centers for liver and kidney, and those are very complicated patients to take care of, but they often do very well. We don't do lungs at our institution. There's only a couple centers in the US that do lung donation, in pediatrics. But yeah, I mean, so we definitely see the positive side of it too, right? Like, this is a child who would have died had they not gotten their
Yeah,
organ. And so
yeah.
there's a lot of positives that come out of it as well. So I think, it's one of those things where, like, you can definitely see the benefit from it, but then the conversations that happen with the families who are donating, I don't think people realize how complicated that process is on the other end. And obviously they're very
No,
grateful.
I didn't know it was that like that. So yeah, I
Yeah.
think that education of the what Western cultures, I count as both as Western
Yeah.
cultures. We don't do death very well.
No.
We don't prepare for death very
No.
well. We don't talk about death very well. My in-laws hate having conversations about death. It's something I think that I'm quite open with, and my parents are open with because it's something that's part of my profession. And hey, we all die, we know
Yeah.
that. But there just seems to be this feeling that if you talk about it, it's real. And the problem is if you don't talk about it when it is real, it's so much harder than it needs to be.
Yeah. Yeah.
And this is for everyone. This is for teenagers. Have this conversation with your teenagers. Have it, if a 14-year-old, have a conversation that, if a child dies and it's on TV, have a conversation. This is my personal thing,
Mhm.
obviously. Have a conversation with your child saying, look,
Yeah.
if you were to die, would you want to be cremated or buried? How would you want us to celebrate your life? And it can actually be a fascinating conversation.
Yeah.
Yeah, there's a book I've seen about, apparently it's quite cathartic and a lot of fun, and it's a book about planning your death. It's a comedy book with lots of quips in it, but it also asks you to write information
Yeah.
so that when you do pass, if your next of kin find that book, then it can assist them in that process. I know when my brother died unexpectedly about 12 years ago now or so, and we didn't know anything. We didn't know any of his wishes.
Yeah.
So it makes it very hard. And it's not just people in healthcare that this happens to, it's every human being everywhere. We need to talk about death.
Yeah. Yeah, and I think that's one of the things that we, especially in pediatrics, struggle with, the idea that their child could die. Um, and
Yeah.
so, we have palliative care in the US, and they're amazing at what they do, and part of their job is to really discuss not just end of life, but really what does quality of life look like? What are the goals of the care that you're going to receive in terms of, obviously we want them to get better, but if they can't get better, then what does quality look like? What is the goal here? What are we trying to achieve?
Yeah.
Whether it's, just time, like quantity, or is it quality? And how do you assess quality? And what does that mean to you? What does that mean to your family? What are the things that are
Yeah.
important to you? What do you want this to look like for them, for yourselves? I mean, these are really difficult conversations, but they are conversations. A lot of times, palliative care isn't around, and we're the ones having these conversations. And so,
Yeah.
this is not something they teach in school. This is not something we get
No.
education on, right? This is just on the job learning for most of us.
Yeah. And quality of life for the patient and quality of life for the family is two totally separate
Yeah.
things.
Yeah.
And so how have you dealt, or how do you find you've been dealing with it when it's clear that the parent's decision is not in the best interest of the patient? Can of worms
Ha,
open.
ha. Ooh, okay, so, yeah, I mean, we
And
have
this is a worldwide medical
yeah,
problem.
we have a lot of absolutely, this is a big topic. We have a lot of ethical situations that arise, some of the biggest situations that I've faced that have driven a lot of burnout for myself have been around these really difficult ethical situations where, kind of like when I was a student, right? This child that was dying and the parents didn't want to treat the pain, um, and
Yeah.
how bad that felt and how hard that was. We have a lot of situations where, you know, the child may be ready, especially in teenagers, right? The child may be ready to give up, because they know that this is not the life that they want. Um,
Yeah.
and the parents just kind of won't let them make that decision. Um, COVID was not bad for pediatrics. We had our little post-COVID surge with RSV and regular viruses that normally would
As
be
human beings
okay,
mixed again.
but
Yeah.
yeah, exactly. They had no immunity to them, so there was a lot of there was a huge surge of patients after COVID. That was our version of the pandemic for pediatrics, and it was no joke.
Yeah.
But in COVID, we had, we took care of teenagers, especially because the adult hospitals were overflowing. A lot of young adults and, teenagers. And this is actually, I think this patient was either 17 or just turned 18.
Mhm.
Um, we had a lot of, especially obese females, were some of the patients that we saw with the worst COVID, that we saw in pediatric world. And there was a lot of debate about whether or not to put patients who are very high risk, on ECMO. And in the beginning of the pandemic, I don't know how much you interacted with this or not. People who met certain criteria were not offered ECMO because their chances of surviving were very low. And so we
Okay.
had
I'm
had,
just going to interrupt and I'm
yeah,
just going to explain to people what ECMO is.
okay,
And correct me if I'm wrong, because obviously I don't deal with it, but it's extracorporeal membrane oxygenation. So
exactly.
essentially, it takes your blood out of your body like your heart does, it oxygenates it like your lung does, and then it puts it back in your body. So it's a heart and lung machine.
Basically, right. So in COVID, it was usually patients' lungs were so sick that they weren't actually able to oxygenate and get rid of the CO2 in their body. And so it operated
Yep.
like a mechanical lung. If they also
Yep.
had bad heart issues, it also pumped systemic circulation to their system and kept their blood pressure up, kept blood flow happening to their body. And so, um, not a small thing to do. Definitely a intervention that has a lot of complications, a very high risk procedure to do. And like I mentioned, it's usually a bridge to something. We don't just do it as a bridge to nowhere. Um, it's very expensive. It's very staff and
Yeah.
personnel intensive. There's stroke complications, bleeding complications, infection complications. I mean, literally, there's like 1,000 things that can happen on ECMO, and they're all bad. Um,
Yes.
the flip side is it keeps you alive. So it's amazing when it works, but I also see it go badly, unfortunately, because it is such a high risk situation. So early in the pandemic, we decided not to put some patients on ECMO that maybe could have survived, but limited resources, limited bed space, limited personnel. The
It's
risks
medical
were
triage.
very low. That the likelihood that we're going to survive was very low, and so we had to make decisions about resource allocation. This is when we were like talking about putting two patients on one ventilator and ventilating. We were.
Yeah.
This was the the dark times of the pandemic where everyone was freaking out about what was possible, what we should do, what we shouldn't do. So that's what we're.
And you can't train for this.
No, you can't. And so we were making decisions about who to put on ECMO, who not to put on ECMO. We had some patients we didn't put on ECMO, they both died. We had a teenage female, almost an adult, very similar situation, very similar risk factors, pretty much almost copy and paste of the other two patients. And we decided to put her on ECMO. Now, she couldn't come off ECMO. She was on ECMO for almost 6 months.
Oh, wow.
6 months. And the moral conflict there, the ethical issues involved, the issues with she didn't really have capacity to make decisions, so mom was making decisions for her. Her life was miserable.
This is gonna sound like a dumb question. Are they awake can they be awake while they're on ECMO?
Yeah,
Yes. So
yeah.
they are conscious. They can be
Actually, they're
conscious.
usually more awake than when they're intubated because we're not worried about the breathing tube coming out because they have
Yeah.
these giant hoses coming out of their neck that are
Yeah.
almost like dialysis, right? Pumping blood out, pumping blood in.
Yeah.
Um, as long as they're safe to move around and they know not to yank at their cannulas, they can be
Yeah.
mobile potentially.
So I'm imagining somebody on ECMO for 6 months, even if they survive, their diaphragm would be wasted. The atrophy of their diaphragm, like they'd have to almost relearn how to breathe.
Yeah. I mean, the amount of ICU, weakness and sort of like debilitation just from not moving their body, not using their muscles, the amount of atrophy. I mean,
Mm.
it's so we were trying to do rehab with her. We were trying to get her stronger. We were trying to get her to a place where she would meet criteria for. She needed lung and kidney. She was also on dialysis, so she needed a lung and kidney
Oof.
transplant, double lung and kidney. And we weren't able to do it at our facility, so we were going to have to work with the adult facilities to try to get this done. And so our goal was just to get her to a place where she'd meet criteria for donation. Um,
Yeah.
and she was nowhere near that and probably was never going to get there. But then the parents, specifically the mom, like, hung on to this idea. Um, and so basically, and this is probably one of the worst cases that we've had in the last 10 years. Um,
Yeah.
and it was heartbreaking. And,
Yeah.
she didn't want to live. When she was lucid enough to tell the nurses she wanted to die, she would. And then she would be out of it again. And then mom was like, no, we're going to do everything. We're going it got to the point where, she'd been on ECMO for so long that her cannulas needed to be replaced.
Yeah.
They're not meant to be in for 6 months. They're not
Yeah.
designed for that. And
Yeah.
so they were starting to have breakdown in their integrity and they needed to get replaced. And so it was going to require basically an open heart surgery to reposition, to repair where the cannulas were and replace with new cannulas.
Yeah.
And she ended up having a really horrible complication on the OR table. And she died in the CICU the next day. Not even in our unit, not even in the PICU. We had taken care of her for
Yeah.
6 months and she passed away in the CICU. And so there was this like huge disconnect and almost like lack of completion for the people
Yeah.
or the healthcare workers in the pediatric ICU because we weren't part
Yeah.
of the ending of it. It was kind of
Yeah.
out of our hands. We didn't make the decisions. We weren't part of the decision making that the family was making with the cardiac, thoracic surgeons, and we weren't part of the end of that. I mean, everything up to the last few days was with us, and then all of a sudden, she passed away the next day in the cardiac ICU, and there was just like this hole. It was almost
Yeah.
like
This
the
lack of closure,
lack
lack
of
of
closure,
yeah.
and then feeling all the tension of this ethical debate of like, well, we shouldn't have been doing this for the last 5 or 6 months, and like, she was in so much pain, she was so miserable that when she woke up, she wanted pain meds, but then we gave her pain meds, but then she was too sedated to do her rehab. And so we're in this situation of like, do we treat her pain and keep her comfortable, or do we force her to do PTOT so that she can rehab enough so she can go to donation? She just wanted to die, and here we are deciding, do we give her pain meds or do we force her to do PT and make her miserable? Like, these are the things we're having to decide, and the family was pushing us to do everything, and, like, this literally tore our unit apart for months, and, like, the nurses.
For differing opinions.
Yeah, I mean, the nurses were basically, "I refuse to take care of this patient because it's too heartbreaking, I can't take care of them." Like, they weren't getting fired from their
Okay.
care, they were
Yeah.
saying, "I cannot take care of this patient or I will quit."
Yeah.
I mean, this happened. I
That's
mean, it
huge.
was
That's
huge, like,
huge.
and the providers the same way. We were like, I don't know how much longer I can actually take care of this patient as a provider either because this is heartbreaking, and this is like I'm making decisions here for this patient that I don't think are in their best interest, but it's what the family wants to do, and this is what we're being told to do, but then you know what I mean? It's like, there's a
Yeah.
situation of, like, there you can't win, and so you're just like,
Yeah.
you're the boat's sinking and you're all on it and it's sinking and no matter what you do, there's no good choice. And
Yes.
it just tears
Yeah.
you apart because, we don't take a Hippocratic oath as nurses that do no harm that the physicians do. But I mean, we have a very similar code of ethics. Like I don't feel good about doing something that prolongs suffering or it creates pain in a patient. And it's not, as a human being, I don't want to be in a situation where I feel like I'm prolonging suffering or that I'm doing something that is against someone's wishes. And unfortunately, in pediatrics, we're in this situation where they may not be the decision makers, and we have to honor the family's wishes. And this is where therapeutic rapport and having these relationships comes into play, because those conversations are hopefully able to get them to understand the situation and maybe turn things towards a more healthy dynamic. But unfortunately,
Yes.
that's not always the case.
Yeah. Yeah. I don't think people realize how much gray there is in healthcare.
Yeah. Oh my God. So
There
much
is
gray.
so much gray, and it causes everyone stress at every level.
Yeah.
From the moment somebody enters the healthcare, and I'm talking first responders, right through to the end of life, or hopefully going home. There is so many gray areas. There are so many differing opinions, and versions of what is right. And the problem is, who's to say anyone's right or anyone's wrong? It's your experience. It's it's your thought, your inner compass.
Mhm.
That's what makes it so hard.
Yeah. Yeah. It's very
You've got to be the
challenging.
one that puts your head on the pillow at night and say, I did the right thing that I could do. That's the only thing you can
Yeah.
do.
Yeah.
And if you don't put your head, if I put my head on the pillow and I'm thinking about it badly, I probably have some learnings.
Yeah, I mean, it's interesting you bring that up because, I mean, I don't know how much you've talked about PTSD on this podcast, but I think healthcare workers, I think it was almost like 30% of nurses and providers suffer from PTSD or some form of like chronic distress around what they do. Not even burnout. Like burnout is even much higher. I think it's like close to 50% of US healthcare workers are burned out. It's higher in nursing than it
Yeah.
is for physicians and providers, but it's like around 50%. Pre-pandemic, I think it was like 40% in nursing. So we went into the pandemic burned out, but we came out of the pandemic even more burned out. So many people left the field. So many doctors went into like consulting or non-patient facing jobs. A lot of nurses left the profession completely. They went into like medical sales, or they went into something totally unrelated to healthcare. And so we're still in the situation where we are incredibly we have this scarcity of providers and nurses and this need that keeps growing and growing. And we have all these new grad nurses that are coming in who don't know anything. And I think the statistic is like 20% of all new grad nurses leave the profession the first year of their job. And I think it's something
Yeah.
like 75% of nurses leave the profession in the first 5 years of their career. And so you have people coming into healthcare who then are not staying in healthcare. And so it's like, what are
Yeah.
we doing to build this resiliency? What are we doing to actually promote people and to be able to continue to do this work? Because it is, as we've been talking about, obviously a very important job, but also really stressful.
Absolutely. And how many times have we already said, since we've been having our conversations, they don't teach you that?
No.
So if you're 5 years out, you don't know squat.
No.
Really, you'll look back in 15 years ago and realize how much you don't know, because all of these healthcare jobs are 95% communication and experience.
Yeah, absolutely.
The sexy stuff, the clinical stuff, is such a minority of the job.
I mean, it's what we all go in for, right? Love the science, we're into the
Yeah,
physiology, it's all exciting. Um, and then, right, like most of the job is human interaction.
absolutely. Yep. It is. It's communication and common sense. And if you've got a bit of that, then, you can do these jobs, but you don't get that in 5 years.
Mm,
Yeah, and over here, paramedics are the same thing. The average expectancy of a paramedic career is 5 years now.
mm.
When I started, it was a career.
Yeah.
It was just something you always did, and you can't learn it in a book. You learn more out of 12 months out on the road than you will in 3 years of looking at books.
Oh, yeah.
Um, and then when you're talking about PTSD, yeah, that's the whole reason I started this podcast, was about PTSD. And I know for the police, I've got a professor coming on in a couple of weeks, and this is her expertise. Organizational trauma in police is 12 times more likely to cause PTSD
Mm,
than occupational trauma.
mhm.
So, what most people think by trauma is blood and guts,
Yeah.
or death or whatever. The harm that an organization does is 12 times more likely to cause PTSD than going and doing your job. That
Hmm.
says it all. It's going to do so it's about going to do your job and then knowing the organization has your back.
Yeah.
And that is in healthcare, when everything is gray, that's really hard because they got your back until shit goes wrong. And that's universal. That
Yeah.
is universal.
Yeah.
Okay, so have you ever been what you would call traumatized?
Yeah. Oh, yeah. Frequently. I think
Yeah.
one of the things that so this is the second part of this journey, right? The first part was I'm going to have
Yep.
less armor as much as I possibly can. And then that didn't work. And then I was going to feel things and be as present as possible. And then I realized I had gotten overburdened with secondary trauma. I had taken on
Yep.
too much stuff that wasn't mine. During the pandemic, I started drinking a lot. I wouldn't say I was an alcoholic, but I was drinking like almost daily, right? Like I would work night shift. I'd come home in the morning at 7:30 in the morning and I'd have a nightcap, right? To go to
Sure.
bed.
They're having
Uh,
breakfast, you're having a bourbon. Yeah.
right. That's totally normal in healthcare, right? No,
Yep.
it's not normal. But you do these things to cope with what's happening to you. And I mean, I think even if we don't meet criteria for PTSD, there's this thing called acute stress disorder, which is essentially like between 3 days and a month. If you have the symptoms of PTSD, but they don't go longer than a month, it's a acute stress disorder. And so a lot of these
Mhm.
symptoms apply. So I actually wrote them down. I don't know if you want me to read them, but they sound very similar to probably a lot of the things that we've got.
Please go. Yeah,
Right.
please do.
Okay. So this is to diagnose acute stress. This is what you need to have: recurring or uncontrollable and distressing memories of the event. Check. I've definitely had those. Recurring nightmares. I've played back scenarios so many times in my head of things I could have done differently or things that went poorly. Flashbacks to the traumatic event. I definitely had those. Okay. Intense psychological or physical distress when you're reminded of the event. Check. Persistent difficulty feeling positive emotions such as happiness, contentment, or loving feelings. Definitely check, right? Like, think about all the times you come home from work or the day after and we're ugly to our spouse or we're ugly to our child or we have anger issues or we don't control our emotions or we're lashing out or we're just moody and irritable and all that stuff. Absolutely. Okay. This is great. You're gonna nod your head yes to probably all these. An altered sense of reality, like feeling you're in a daze or as time is passing in slow motion. Memory loss regarding important aspects of the traumatic event, right? We block stuff out, we dissociate. We don't remember exactly all the details that happened. And that's super common. Efforts,
It's one way or the other, or we remember every single detail.
right? We perseverate on every little tiny thing that happened and we second guess everything that happened in the moment. And did we do the right thing? Did we
Yeah.
not do the right thing? Okay, right. Um, Efforts to avoid distressing memories, thoughts, or feelings associated with the event. So things that we do to numb the pain, distract ourselves, all the different avoidance tactics of actually not dealing with what's going on with us, right? Efforts to avoid external reminders associated with events. So certain people, places, maybe it's your workplace you avoid, right? Things you call sick even though you're not sick because you don't want to go into work. That's a super common one.
Yep.
Disturbed sleep. I definitely have had that one. Absolutely. Irritability or anger outbursts. We already talked about that. Excessive attention to the possibility of danger. You're hyper vigilant all the time.
Yep.
Absolutely.
Yep.
Difficulty concentrating, definitely. An exaggerated response to loud noises, sudden movements, or other stimuli, i.e., your startle reflexes, super hyperactive, right? Okay, all those
Yep.
are the criteria for PTSD. If it doesn't go on longer than a month, they call it acute stress disorder. Think about how many times you have been in acute stress disorder and then you come out on the other side of it, right? Like
Yep.
something pulls you out of it, you come to the other side of it, it doesn't
Yep.
go into full-blown PTSD, but, like, you suffer these traumatic events that happen to you time and time again, and then you respond like anyone does to trauma with these symptoms, right? You may not have all of them, you may not have enough to have a, quote, "diagnosis" by the DSM, but you're going through this process of having secondary trauma, and it wasn't you, right? It didn't happen to you, it wasn't your child, you weren't the one injured.
Yep. Not my tragedy.
But you still feel it. It still affects you.
Absolutely.
It still weighs on
Absolutely.
your soul. It still takes its cost, right? And so this is what I came to realize is that I was suffering too. I was taking on too much. I was taking on stuff that didn't belong to me and owning it. And so what was I going to do to fix that? So I've had a yoga practice for 20 years plus years, right? I married my yoga teacher, like I said. Um,
Yeah.
and so and I've had a meditation practice kind of on and off throughout this time. And so I turned to mindfulness exercises and meditation, spirituality. And what I had realized is that I was operating from a place of ego. I was operating from a place of I am the healer and I am healing you who is the sick person, and how that creates this duality, right? It creates this separateness. Instead of seeing myself in the patient, instead of seeing myself in the parent that I'm helping take care of, right? I'm seeing them as someone who needs me to do something for them. And I'm putting myself
Yep.
in this position of authority or of power or of someone who is doing something to somebody rather than just, hey, we're all humans having a human experience. And I'm fulfilling this role as part of this journey that you're on. And this is my journey that I'm on. Um, but this is out of my control. This is out of my hands. If something bad happens, it's not because I fucked up, right? This isn't my fault. I did the best I could with the knowledge that I had with the situation that was presented to me, and I would do the same thing time and time again, and that the
Yep.
outcome is not mine to own, right? Even if it goes well, it doesn't mean that I'm an amazing nurse practitioner and, "Oh, I'm so great," and pat myself on the back. Things don't go
Yep.
well, it's not that I fucked up. This is life, right? And who am I to control what's
Yep.
gonna happen to a patient? It's out of my hands.
Yep.
So
That's an outstanding, that is an outstanding and therapeutic way of looking things, and it resonated with me hugely. I've realized through my process of going through this PTSD journey that I made myself the center of my own story too often. It was my superhero cape.
Yep.
I've said that to many people. Who am I if I'm not a paramedic? Because
Yeah.
that's who I am, because that gives me respect, and therefore I'm that. Whereas I didn't know who I was when and the first thought, the reality of when you realize that this is maybe not something that I can keep doing
Mhm.
is it's a grieving process because I didn't know who I was. So I started my true healing. I'm still very early on, and despite it being a couple of years, I'm still very early in the road of healing.
Mm.
When I went into a private psychiatric hospital and did an inpatient PTSD course,
Yeah.
and I knew what PTSD was. I have been to hundreds of people and I've experienced it for nearly 20 years. But there's something about reading it and ticking the box when it's about you
Yeah.
and being open and being vulnerable to own that you are not your job, you are this person,
Yeah.
you have experienced this, and then to sort of come to grips with that. And then I found that when I came to grips with that, I then had to allow my wife to come to grips with that because I had put so much of who I was within my job that that became who I was. And then when I realized that I probably am not going to be able to go back to it, then she also had to understand and
Mm.
go through that own process of
Yeah.
understanding that she thought I'd given up. Whereas I'd actually decided, no, I choose you and I
Mm.
choose me
Yeah.
over that. And I'm going to fix me.
Yeah.
And fixing me is a different road. Now, it doesn't mean
Mm.
it's not paramedicine. It doesn't mean it's not this, that, or the other. I don't know what it means, but
Mhm.
it means I'm open to anything and I'm okay with that.
That's beautiful.
It's
Yeah.
hard. So when you came to these conclusions and we've gone through that list and you realized that, you had a lot of these symptoms, was it a therapeutic process to get this out?
No, actually, I went to a meditation retreat for a weekend and spent a lot of time sitting with myself, and
Yep.
I sobbed for, like, hours. I
Yeah.
released all this trauma that wasn't mine. I released all this heaviness, this sadness, this you you don't realize how much you're carrying until you actually, like, really go deep inside and really feel what you're feeling, instead of numbing it out, right? I quit drinking alcohol.
Yep.
I haven't had a drink in almost a year. I mean, I may occasionally have a glass of wine, but like I stopped drinking booze. Um, I I changed a lot of my lifestyle habits, and I really went deep into my spiritual practice, into meditation, into really being in touch with who I am and what's going on with my psyche, with my emotions, with my soul, right? Like I want to
Yep.
be present in myself, in my body. Um, and that's how I'm choosing to live right now. And so, yeah,
Yep.
these situations are happening that are really intense. That story I told in the first part about the mother who didn't want to donate and wanted to have her death be the way she wanted it to be. That was after I'd come through this process of realizing like I'm just an instrument for something bigger than myself. And if what needs to happen in the situation is for this mom to hold her child as he's passing, and that's what she's wanting, and I'm the instrument for that to happen, then I'm just in service to something bigger, to some higher,
Yep.
whatever you want to call it, God, whatever. I mean,
Yep.
I I don't have a specific religion or dogma that I follow, right? But like I I can say that there is this sense of being of service. Um, that is to something bigger than me. It's not about me. And
Yep.
so there's something liberating in that. And there's also something really empowering about that because if I'm not acting from a place of I, of self, of ego, then the capacity that I have to hold people in these states is infinite, actually, because it's not
Yep.
me doing the work. I'm not the one holding somebody when their child's dying. I'm not the one comforting him. It's not something that I'm producing or that's creating, that it's a creation of mine. It's something is being moved through me and I'm just the vehicle for it.
Yeah. I'm loving hearing what you're saying. And to me, it's bringing just the words grounding and mindfulness. And if you told me those words, grounding and mindfulness, 3 years ago, I'm thinking we're doing a hippie, kumbaya. It's not until
Yeah.
you actually realize what that is. And I needed to be taught it. I hadn't done yoga. I'd never done yoga before. I did it in the clinic and they had meditation sessions and ground work and stuff like that and breathing. And it is a different experience. There's something about going outside in the grass and putting your feet on the grass,
Mm.
not in shoes, just touching the earth. I am not a yoga or I'm not a spiritual person, but grounding, I almost want to come up with another word for it because grounding has
Earthing. Earthing, Peter. It's called earthing.
yeah, yes. But people just have such a negative concept of, that sort of hippie movement kind of thing.
Yeah.
Mm. But it bloody works.
Yeah, it does.
It really does. It, it,
Yeah.
it makes you, I know if I'm having I, so I've recently come off some medication and it's been a shit week.
Mm.
It's been the first time I've ever had withdrawals from an antidepressant and I have hated it.
Yeah.
I have been the grumpiest bastard on earth. I've been dizzy and I've been snapping left, right, and center.
Mm.
So my poor family have gone through that with me. And I just, I went for a walk and I walked and then I took my shoes and socks off and I stood in a field,
Mm.
like a footy field that's around the
Nice.
corner.
Yeah, yeah.
And I came back and I just felt better. It just, it could have been the walk. That's never going to hurt anyone. But having just touching the earth, it just taking a second of, yeah, I love the beach. Doing it on a beach is the
Mm.
same thing. If you've got an option of that, if you're close to it, but sometimes just looking at the earth and looking up, you realize how small you are
Yeah.
in whatever the hell this is.
Yes. Absolutely.
And it's if you're going through those a lot of the lists that Adam read out before, you don't have to have every single one of them to be having an issue,
Mhm.
and having one of those doesn't mean you've got a problem for the rest of your life. Most of those are natural reactions
Yeah.
to abnormal events. They're as we say, it's a normal reaction to an abnormal event.
Yes.
An abnormal to a reaction to an abnormal event is carrying on like nothing happened.
Right.
That's more scary.
Which we have to do all the time in our career, right? Like how many times,
Absolutely.
I mean, in the ED, like, I would go and do CPR on a child, and maybe they didn't survive, and then I have to go to the next room with the patient who has strep throat and give them Tylenol and give them the discharge paperwork and act like I didn't just
Yep.
have a child die in front of my eyes, right? Like, how many
Yep.
times do we have to force ourselves to do things that are completely out of the nature of what we're meant to be as human
Humans.
beings, right?
Yeah.
Like,
Yeah.
it's denying what was actually what's natural. We do it all the time.
Absolutely. Yep. So I really recommend that anyone in a traumatic job, and when I say trauma, it's not blood and guts. Trauma
No.
is not blood and guts. Trauma is your brain reaction to a scenario. Doesn't matter what it is. Um, I'm trying really hard. I want to get a professional sports referee to come on here, and there's one specific one I'm chasing because they have a traumatic job
Mhm.
because they cop death threats. Everyone hates the referees,
Yes.
but they're probably the most important person in a game, and they are human beings. And trauma is that it's how you perceive the world and how you accept the world. And being traumatized is not a bad thing. It's
No.
how you it's a natural thing. It's how
Yes.
you go beyond. And so and this brings us to your next step.
Yeah.
So you've identified all this sort of stuff and and I think if do you think you would have known or realized any of this if you hadn't done yoga teaching?
Um, I think it was for me the way through.
Yep.
So, I don't know how much you're familiar with like depth psychology and personal development, but there's this phrase called katabasis, which is the descent to
No,
hell.
I'm not aware of it.
So, in order to go
The
through
the
self,
descent to hell.
yeah, basically. So it's in any kind of like psychological development, individuation, self actualization. There's this process of actually going down into the depths, into the darkest spots, and then through it. So you have to go down and out or in and through, right? Like you have to go into it to get to the other side of it. And
Yep.
so I think my process was really like going into this darkness, into this shadow, into these things that are really difficult to look at and really hard to face, and finding a way of working with them that is actually healing. Um, and a lot of times they say like the wound is where the light comes in, or your wound is where your
Yep.
gift lies.
Yep.
And I think what I had realized was this was my wound, and this is also the thing that I have to offer to other people. And so, in this process of realizing this, I decided to go back to school for psych mental health. And so, this is the next phase of my career where I want to work with healthcare workers. I want to work with families who've had a child that's been in the healthcare system, people who themselves have been patients in the healthcare system, people who've been affected by things that I have been part of, understand, have the context for, and can hold them in that and really work with them to kind of find a way of holding that in themselves in a way that is healing, that integrates into their experience, that is part of how they choose to move through life, in a healthy way,
Yep.
right? Instead of with a way of avoiding it or numbing it or going to substance abuse or quitting their career that they love or all the different ways that we use to cope or the things that we do because we don't think we can go on anymore, right? Like, what a loss would it be if I mean, you may not have to go back to paramedic medicine, but if you just, someone who has 20 plus years of experience, what a gift you have to bring to that field. And what a loss it would be for you not to continue to do it. And obviously, your evolution may be to do something totally different, and that might be the beautiful phase of your next thing. But for other people, right, physicians who trains their whole life to be a doctor and their specific specialty, and then they feel like they get to the point where they can't do it anymore. What a loss! Like, what a disruption to their life. It just feels like such a waste. To all
Yep.
these nurses flee the field who, used to be that you were an ICU nurse for 30, 40 years and then you retired. No one did it for
Yep.
like 2, 3 years and then, oh, I'm going to go to a different unit because I don't like the ICU anymore. Like, it was something that you did, you stayed in forever. And like, I can count on my one hand the number of nurses that are been in that unit for more than 10 years, right? Like, it's just
Yep.
we're not built for it anymore. We're not getting the skills. We're not getting the kind of way of framing these experiences that allows us to integrate them and not destroy us, frankly. And so this is sort of
Yeah.
where I want to move into my career in the next phases. And there's some like really exciting developments that are coming with, PTSD specifically. I don't know if you know that the MAPS trial with MDMA, it did not get FDA approval, but I'm sure that they'll do another phase 3 trial. It'll go through those phases again. But there's all these things happening with psychedelics that are new, that I think are really exciting, that are different ways of treating depression, anxiety, PTSD, all these things that don't really have a lot of great therapies for, that are part of doing this deep personal work, that it's more than just, I'm going to do this until I can't do it anymore, right?
Yeah.
I think that there are ways for us to either build a practice around it that allows us to continue, or do personal work that allows us to continue. But there's got to be a better way than, I'm just going to do this until I burn out or I get depressed
And it
or
can't be that it can't be that we leave the system the way it is when it's not working,
correct.
and there are these things like, the MDMA, psilocybin, so mushrooms, for people that don't know what we're talking about, like, there's a lot of research going on, mainly in other countries, because this stuff is not big pharma.
Nope.
So, that's a whole, it's a whole nother beast. But there's so much research, especially with war veterans, on how beneficial microdosing of LSD, MDMA, psilocybin. Apparently, they've got amazing healing properties, and they have been life-changing for people. But in most Western cultures, I know over there, a lot of people go to Mexico to get it and have the experiences and things like that. And I'm glad they have access to it. Over here at the moment, we've only kind of recently done legalized CBD oil. We don't, marijuana is not legalized, but there is medicinal cannabis use, but it's very strictly run through doctors and a prescribing thing. Work cover currently don't allow. So work cover is like our job insurance agency. They don't currently allow you to take marijuana in any way, shape, or form during treatment. They won't pay for that. Whereas DVA, which is our Veterans Affairs department, which is a federal thing, they'll pay for that. So it's also hit and miss. It's all over the shop. Ultimately, when things are naturally grown, there's not as much money to be made. So you wonder whether that gets involved, and people can say this is political or not, but it's the truth. If there's shit out there that has worked and can work and does work, get it out to the people and let them trial it. Because if people are at the end of their tether with PTSD, if they can have a life-altering experience under medical supervision, then what the hell's the harm?
Yeah. I think people are scared, right? They're scared of these things.
Yeah.
They don't understand them. They don't.
They've got scary names. They've got scary names, and they're associated with the old swinging 60s and the hippie 70s.
Yeah. I think my hope is
But
that
there was a reason they came well. They were big in the wartime. People came back from Vietnam and they did it, and a lot of them fixed it. What people? One thing that I heard recently was over I think it was Vietnam. It could have been World War II. So forgive me if I've got those wrong. Is there was a lot of use of heroin from soldiers while they were over and deployed.
Yeah.
But that heroin use stopped as soon as they got home because they didn't need it.
Yeah.
They used it as a medication to get through hell. They didn't need it when they got back. So these drugs, and heroin is a highly addictive thing. It doesn't, and if these people, these soldiers that have seen things that I can't imagine, have come back and they've been on heroin for a period of time, and we're probably talking weeks or months, and then they've come back and been able to stop it cold turkey because they don't need it anymore, then that to me opens my mind to other drugs. What can be used in different situations with different psyches.
Yeah.
Now, there are people that get super affected by marijuana, and it opens up schizophrenic psychosis and all sorts of things. Should it be banned for everyone because that can happen? No, it should be watched. It should be cared for and so to stop people accessing things because of a stigma or because there's no money in
Mhm.
is one of the downfalls of our societies at the moment, in my opinion.
Yeah. No, I think there's a lot of big clinical trials that are happening all over the country. My employer is actually doing a big one on psilocybin right now too, and so I think it is the cutting edge of mental health. I think you're going to start seeing a
Yeah.
lot more of it, and I really hope that it ends up being something that is in the hands of people who are professionals, who do have the right training, that do understand how to use it, where to use it, with whom to use it, how to use it. Because I think it's a very powerful tool, but I also think there's a lot of, I mean, I don't know how much you are getting these sort of things, but right now Colorado has personal use of psychedelics. Oregon just has a regulatory program for psilocybin. And we're already starting to see all these stories about, the pilot that was on psilocybin at a facility, and the next day he tried to down the plane because he had like some weird like hallucination, or it
Yeah.
was like dissociative experience where he was trying to basically bring the plane down. So you're gonna get these
Yeah.
stories that are gonna happen where, you get all these scary cautionary tales that are gonna come up. Um,
But at the same time, how
yeah,
many times in every country does somebody get absolutely wasted on alcohol
oh,
and get on a plane and
absolutely.
cause an issue? And we accept that,
Yep, absolutely. So,
that's just,
yeah,
yeah,
I think there's a place for it. I think that it will be. I think it'll start to make its way into mainstream mental health and mental health therapy, in the next probably couple of years. So I think there's some very
yeah.
exciting
We're
things on the
not we're not
horizon.
advocating and we're not talking about people dropping pills and having this massive hallucinogenic, for hours and hours and hours. That's not what this stuff does.
Right.
This is clinical and therapeutic
Yeah.
stuff. It's microdosing done under medical supervision.
Yep.
Um, I've never done it. It is, as far as I'm aware, it is still illegal over
Yep.
here. It may have been decriminalized as far as possession is concerned to allow trials to happen
Mhm.
within very strict circumstances.
Yeah.
So I think, they have to declassify something because otherwise you can't even have it for trials. So I believe that's where we're at in Australia, that certain things like the MDMA have been changed their classification where trials can
Mhm.
happen. I'm all for it. Go
Yeah.
for it. I'm not a fan of saying blanket, everyone can have a
Yeah.
go. Let's all go get wasted and have a party. That's not helpful to anyone. But
Yeah.
we've got to see where these things go.
So I'm very hopeful for the future. I think that there's, a lot on the horizon. I hope that for healthcare workers, hopefully it's a potential option to really do the work and to really heal from all these traumas that we accrue in this profession.
Yeah. So you're doing study for it now? Is it like a postgrad or is it a new bachelor kind of life?
I'm doing a postgraduate certificate, so it's
Yeah.
like a postmaster's. I'm just taking the classes so I can sit for the board so I can get my license. So it's like 2.5
Okay.
years part-time while I'm working and have a family and everything like that. But
What
yeah,
license would that bring? What
uh,
license will that give you?
psych mental health nurse practitioner.
Yeah. Okay.
Yeah.
Okay. Do you see yourself continuing in the pediatric space, or you think want to? No.
Yeah, I think what I realize is that the most meaningful experiences that I've had have actually been with the parents of the patients that I'm
Yeah.
taking care of. And also really
Yeah.
wanting to work with people in the healthcare field like myself, like healthcare workers who got to the point where I got to and maybe weren't able to break through the other side, right? They just need someone to kind of help guide them, whatever their answer is going to be, right? It's my solution is
Yeah.
not going to be everyone's solution. But how can I hold people in that process that they're in, and how do I build some longevity for people? How do I help heal this secondary trauma that we're all suffering from? Because I think
Yeah.
it's a big issue, and the systems itself isn't really taking care of it. And we talk about resiliency, we talk about self care, we talk about all these things that are supposed to make us feel better, but how much are they actually doing? And I think the systems that are in place are woefully inadequate.
I hate the word resilience. To me, resilience means you're on your own, deal with it. You should be doing better.
Right. Self-care, do it
That's
yourself.
it's such a political. It's a political. It does have it does have a healthcare meaning, but I think it's used nowadays to basically say, deal with it.
Yeah.
Be resilient. Suck it up, princess.
Yeah.
It's a word I hate. I know it's used in political terms often. This town's resilient. No, they're ignored and they've learned how to do it themselves because you won't look after them. There's and resilience is necessary. Everyone has to have some resilience because otherwise everything breaks. What was that saying you were saying? Was it Latin or something?
It's a
The
Latin
journey.
word. It's catabasis, which is to go down or to go in and out. So you got to go
Yeah.
through the hell to get to the other side, to get to the light.
And it's so true. You cannot feel joy if you don't feel pain.
Yeah.
You cannot feel love if you don't feel loss, grief. You can, emotions have to have opposites for you. If we were all happy all the time, we'd be numb
Yeah.
because it's our normal.
Or it have
You
any
need
meaning.
that spectrum. Exactly. It would just
Yeah.
lose everything. You would be just a robot. You'd be a thing. You'd be an AI. You'd be a robot. So we do need to understand that if we're going through a hard time, through work, through trauma, through PTSD, through whatever, there is another side. We can come out the other side. I am not there yet, but I'm not. I know that there is another side, and I think when you don't recognize that, that's the most dangerous time because you're hopeless.
Yeah.
And if you're hopeless, your danger matrix has gone through the roof. You need hope. If you're loneliness or worthless or hopeless, or combine all those three together, your risk of suicide is through the roof.
Yeah.
So, if my advice to loved ones of people in the healthcare fields or anyone in any traumatic field is allow them to be where they're at and feel the feels, but encourage them that there is the other side.
Yeah.
And better days will come. And and then you can get through it. It's when you don't think there's a better day, that's when you're in a bit of trouble.
Yeah. Beautifully said.
All right, Adam, is there anything else you want to add, mate? I'd love this chat. I love your journey, and it's a special job you do in the PICU. I love the fact that you're transitioning to a healthcare carer
Yeah.
role,
Right.
because it's you can't teach. Somebody can't come and talk to a healthcare professional who has never done the role.
Exactly.
You need that background. If you're a psychologist and you've just had your degree and you came to me and you said, life must suck, I know what you've been through and this kind of thing, you haven't got a damn clue. You can't learn that stuff in a textbook. You learn it from life, you learn it from doing, and the fact that you're putting it to use to help people in your own field and other fields, mate, I take my hat off for you. And I wish you luck. I'd love you to keep in touch. And if you come up with something you want to talk about, this is a group that we specialize in PTSD and the trauma. If you've got stuff you want to bring out, then please get in touch. If anyone has any questions for Adam, come through me. So beyond the call, peter@gmail.com or via the Facebook or Instagram page or whatever. And I can forward your stuff on to Adam. Adam, it's been an absolute pleasure to meet you, mate. Thank you. It's been, it's been a good chat. That's 2 episodes of about an hour long. So yeah, that's awesome.
Yeah.
I appreciate it, mate. I wish you love to the wife and your boy. What does the boy want to do when he grows up at the moment?
He said he wanted to be a police officer last time the school asked him. So give him what you told me.
Yeah, right. Yeah. Okay. That's scary. Look, I've got nothing but respect for police everywhere in the world. How they do it over in your neck of the woods, I've got no idea.
Yeah.
So, mate, thank you again. I wish you luck. And thanks, everybody. And we will talk to everyone soon. Thanks for listening to this episode of Beyond the Call. If you like what we're about, please make sure you subscribe, and if you can leave a review, that would be appreciated. If you have feedback or suggestions for future guests, please contact me via my socials. Please share with your networks and help me expand my reach. It's a great privilege for people to share their stories and allow us to go beyond the call.